So we'll move on to the shoulder here in 2016 and just talk about some technical things. If I can get this to work, there we go. We don't need to go through that. As far as the report, obviously you need to develop your own system. I typically start with the first paragraph talking about the shape of the acromion and impingement, second paragraph talking about the rotator cuff, the third talking about instability lesions in the labrum, the fourth about the bones, and then the surrounding soft tissues. You just need to have a system and make sure that you follow it on every report. So looking at the shoulder, today we're going to talk about technical considerations. In future lectures, we'll talk about impingement, rotator cuff disease, instability, and some other topics within the shoulder. Now, protocols, there are many different ways to do good imaging of the shoulder. Mine is a little bit different than a lot of people use in this day and age. I like 3 sequences in the coronal plane, 2 in the axial, and an oblique sagittal, and I don't like to use as many fat suppressed sequences as most people like to do. And the reason for that is the fat suppressed sequences are very sensitive, but they lack some specificity, and I've found over the years, more and more now with MR imaging, that specificity, I think overall is more important. I think there's too much surgery, and it's often driven by MRIs which are overly sensitive and not specific enough. So I find that the non-fat suppressed T2s add some specificity to the diagnosis to decrease the number of overcalls on MR. But we'll go through this and you'll come up with your own opinion concerning it. So let's just talk about some of the techniques. So a T1 weighted image allows us very good visualization of the bones and the fat and the cortical margins, which I think are important, especially when we're talking about chronic degenerative disease. Remember, the vast majority of people who have injuries to the shoulders, they're not acute injuries, they're chronic. And we're dealing most of the time with chronic problems in older individuals. And in those patients, the T1 weighted images really allows us to see the osteophytes, the eburnation, the degenerative disease, which may affect the management of the patients. Those are less well visualized on the other 2 techniques here. The T2 weighted image we can see here also allows us to see the cortical margins, but the fluid is very bright. But other tissues like articular cartilages are dark, which I think adds some specificity to the diagnosis of cartilage lesions that we'll be talking about. And then the PD FatSat is another one that's very sensitive. We can see margins very nicely with the PD FatSat. I think in the oblique coronal image, this is a very important image. But I tend not to use it quite so much in other planes, though we'll use it at high field in the axial plane as well. Now in the axial plane, again, I like to have a T1 weighted image, which is mostly used for osteophytes and degenerative disease like we're seeing in this individual, but it shows anatomy very well. I like a PD FatSat image in this plane, and later on we might talk a little bit when we get to the physics sections about the exact T2s that can, the TEs that can be used. A lot of people like T2 weighted fat suppressed images, but I don't like that as well. Certainly the fluid interfaces are better here. The articular cartilage is a little bit darker than we see on the PD FatSat, but we lose a lot of signal to noise, and I think therefore we lose a lot of adequate edge detection. So I tend not to like the long TE fat suppressed images, but other people may disagree. Now, MR is very sensitive for blooming artifact, for little areas of metal after surgery. As you can see here, you can just barely see it on the CT scan, but we see a lot of blooming artifact. You're all well aware of that. But this is a Major League Baseball player after labral repair. These small, almost microscopic foci of metal in the joint space after arthroscopy. I was talking to a surgeon recently who's being sued because of this. There is no known adverse effects of this microscopic metal in the joint space after arthroscopy. We see it fairly commonly, and I don't know of any known adverse effects. But be aware that these can involved right now with one of our referring physicians trying to help him out, where he's actually being sued because of this, and it's not a malpractice in my opinion. So that's a metal artifact you're familiar with. Low field, I changed the protocol a little bit. We can't do the PD FatSat so well at low field, so I like to substitute the stir. The stir is not really good in the axial plane, so I tend to use a gradient echo in the axial plane in lieu of the fat suppressed at low fields. Otherwise, it's very similar. With arthrography, I changed it a little bit. We put contrast into the joint space. I continue to have the coronal T1, the coronal T1 I replaced with the coronal T1 FatSat. I keep the T2 without fat suppression, and then a PD FatSat. In the axial plane, I do a T1 FatSat, and then the sagittal is a T2 no FatSat. So it's a little bit different protocol. However, even though a lot of radiologists love arthrography, it really hasn't been shown to increase the diagnosis of rotator cuff tears, at least at high field imaging. So I'm not a big proponent of it, but a lot of people like it. And I think some surgeons like it because they feel that it increases the sensitivity for detecting tears, but at high field there's not good evidence to support that. So here we can see a contrast in the joint space. This would be the T2, T1 FatSat and the PD FatSat images in the oblique coronal plane. Here we can see a little bit of extravasation of contrast actually into the supraspinatus muscle. And then you can also, because depending upon the exact way in which you introduce the material, a lot of people like to go through the rotator cuff interval here. Sometimes you can get extravasation of the rotator cuff interval and occasionally get small amounts of contrast into the subacromial bursa and the subcoracoid bursa, but that's basically normal just from the tract of the injection. Just be aware of that. And here's the tract going through the rotator cuff interval, leaving a little bit of contrast in the subacromial subdeltoid bursa. Just be aware of that. Now, there was a paper many years ago in radiology, probably I think around 1990, something like that. There were two papers in back-to-back issues of radiology. One said that MR was highly accurate in evaluating rotator cuff tears. The other one said MR was no better than flip of a coin. And if you go back and look at the difference of the two, one scanned at a 24 centimeter field of view, and the other article was scanning at a 12 centimeter field of view. So it really all came down to resolution. And the resolution is important. It's a problem more at low fields. Well, actually, depending upon what you're looking at, resolution can be a problem at MR at all fields. But most of the things we look at in the shoulder can be adequately seen at high field as long as we use a relatively low field of view. I like to use a 15 centimeter field of view with something like a 256 by 192 matrix that gives us reasonable resolution and a reasonable amount of scan time. Otherwise, you don't have the resolution to really see the structures you need to see, like the labrum. Consequently, when we go to low field, I still think you have to have the resolution, but I just compromise signal to noise. So at low field, I look at grainier images at the shoulder. A lot of people, when they go to low field, they increase the field of view, decrease the resolution, so you have an image that looks pretty, but you don't have the resolution to make a diagnosis. So a lot of people will criticize mine because they're grainy, but you have to have the resolution, because there are a lot of studies down in the old literature showing without the resolution, you're not going to be able to make diagnoses. And the signal to noise turns out to be less important than the actual resolution, in my opinion. The anatomy, I guess we really don't have to go through this in this group. Here we can see the scapula, the acromion process coming out posteriorly, the distal clavicle, the acromion, and like to look at the shape of the acromion. As we'll talk about in impingement, different shapes can lead to different risks of impingement. And in the axial plane, we can see the labrum, the inferior part of the joint space here, and the more mid portion of the joint space superiorly. Another thing that you'll occasionally see is a central defect in the articular cartilage of the central glenoid. This is a known congenital variation called a central defect and shouldn't be interpreted as an abnormality. Now, this is an individual where we can see here a little structure coming across anteriorly in this location. And you can follow it all the way through. If we go in the oblique, the sagittal images, we can see it coming across like this. Anybody have an idea of what this structure is? See it coming underneath the supraspinatus at this point? Okay, so this is an anomalous insertion of the pectoralis minor tendon. I just don't want to show it as something to be aware of. It's a fairly uncommon congenital variation, but it can be seen here. It comes across here, and you have a variant that goes up through the shoulder in this particular process. Here's another example where we see one coming across here in the axial plane. You can follow it all the way through out to the pectoralis minor muscle over here. And if you can look at this in multiple planes, one thing sometimes you can see it as a prominent band underneath the supraspinatus tendon coming through here. Just be aware that this can be an anomalous insertion of the pec minor. And there we see on the coronal plane where it looks like there's kind of a little thickening. Sometimes you'll see tendinosis in the supraspinatus, and then this big thick thing which looks like it may be a retracted portion of the supraspinatus partial tear. But if you follow it all the way out, you can often see it going into the pectoralis minor. So I just want to point this out as a variant to be aware of. It was originally described back in the 1800s, so it's not new. And it's here just an example. It's about 1% to 2% of patients. And just other examples in the literature. And I don't think we need to spend a lot more time on it, but just be aware of that. Okay, let's see. Let me see. I guess I'm a little tired of talking here. Jonah, what do you think of this case? 16-year-old male with pain.
Okay, so oh, gotcha. Yeah. Okay. So yeah, I guess we're looking at perhaps a congenital.
The issue here is what should be there that you don't see, and these can be the difficult.
Oh my God! Yeah, these are usually tough for me. Okay. Well, one thing I'm not seeing, and maybe we're not coming through it, but the biceps.
Okay, so there really is no biceps tendon.
Okay, good.
If you go through, there's no bicipital groove either.
Oh, yeah.
Case. So these are just some vessels out where you might expect the biceps tendon to be. And again, we don't see a biceps tendon here. All the way down.
Okay.
Right through here. We also here. This is a congenital absence of the biceps tendon. Now, I think in order to call it congenital absence of the biceps tendon, if it's not there, you won't develop an intertuberous groove, so you won't see the groove in the bone. If you have a tear of the biceps tendon at an early age, you'll have the groove, but you just won't see the tendon. So for truly to be a congenital absence of the biceps, I think you have to not see the intertuberous groove.
Was it only the long head? Was this only the long head, or actually was both
only
head?
the
long head, right?
Yeah, only the long head. Okay. Okay, and here's just another example where we don't see the intertuberous groove here. We don't see a biceps tendon. This is a 23-year-old male, and this is another congenital absence of the biceps tendon. Okay, so now in looking at the biceps anatomy, let's talk a little bit about the bicep sling, because this is going to be important when we talk about pathologies. Now, the biceps anchor, occurs just superior to the superior portion of the labrum. And that's where the biceps anchors into the superior tubercle of the glenoid in that location. Then the biceps tendon comes out, as you know, over the head into the intertuberous groove, and then goes distally to the biceps muscle. Now there is a structure which actually attaches to the glenoid just anterior to that, which comes under the biceps tendon. Let's see, which is great, the superior glenohumeral ligament, which comes around in that location. And this is called the sling, which helps hold the biceps into normal location. So the superior glenohumeral ligament really comes out underneath the biceps and folds around it like we see in this particular anatomy. We'll come back to talk about that when we talk about biceps pathology and displacement of the biceps. But just remember that anatomy. We'll come back to it later. Okay, so let's talk a little bit about technical considerations when we're looking at rotator cuff disease. So I can talk a little bit about fat saturation, arthrography, and T1 FatSat versus T2s. Now, I was at one of David Stoller's meetings quite a few years ago, back in 2003, and Dick Hawkins, who was then at the Stedman Hawkins Clinic in Vail, he's since moved to South Carolina, I think, talked about what he wanted to know from the radiologist when he sends a patient for an MR examination. He wanted to know the size of any tears, the quality of the tissues, the location of the tears, whether or not there's fatty infiltration into the muscles, whether there's an elevation of the humeral head. He wants to know the acromial morphology and the status of the biceps. So these are the 7 things he wants in every report if someone has rotator cuff disease. So let's just kind of go through each of these things. Well, actually, we won't do it now. When we get to rotator cuffs tear disease in a couple of lectures, we'll go through each of these 7 things and how to evaluate it on an MR examination. Now, when we look at rotator cuff disease, there are some things that have high sensitivity. There are other things that are relatively high specificity, and often there can be confusion. So a lot of people believe that the high sensitivity is MR arthrogram for disease, followed by PD FatSats, followed by the non-FatSat T2s. There can be a lot of confusion with arthrograms that we'll talk about that can actually put it kind of both high and low and can cause some confusion. When it comes to specificity, the non-FatSat T2s is more specific than the PD FatSats. So when I report pathology of the rotator cuff, I really like to use the T2s to describe it. And we'll talk about that when we get to rotator cuff disease. Much more just location. Here, when it comes to sections, the coronal plane is one of the best planes to look at the disease of the supraspinatus tendon. But in locations, we also need to look at the sagittal images to determine the anterior-posterior component. So you really need to use both. The axial images are not great for this. They're better for the subscap, as you all know. So typically what we see with a degenerative tear of the supraspinatus tendon, we'll see a lot of signal abnormality on the T1. We don't see the tendon as a black structure going all the way to its insertion, but we really can't see much detail for the tendon. So the T1s really are sensitively detect pathology within the tendon, but they're not specific in letting us really know what the pathology is. If we go to the PD FatSats, we can see a lot of abnormal signal intensity also. Clearly we can see areas where there's fluid, where there are complete tears, and we can see the end of the torn tendon and a little stub at its the old insertion on the greater tuberosity. We can also see a lot of tendinosis within the tendon, letting us know that this is most likely going to be a tear with a chronically diseased tendon, which is the vast majority of rotator cuff tears we see outside of young athletes. Now, the T2 FatSat, what it does is it allows us to much better determine the extent of the tear. And we found, comparing with arthroscopy, now it's hard to compare with arthroscopy. And the reason, and we've done several studies with Curl and Job where we've looked at athletes trying to size tears. The problem with arthroscopy is that the size of the tear is really going to vary depending upon the positioning of the shoulder, how much fluid you put in, and what you do to the tissues with the arthroscope in there. But in general, we felt that we over-describe the size of the tear on PD FatSats and more accurately describe the size of the tear on the T2 weighted images, because we can see the margins of the tendon, and it's easier to differentiate the tear from tendinosis on the T2 non-fat suppressed images. So this is the technique I like to use to primarily determine the size and the location of tears. Okay, and now as far as contrast, so here's a T1 weighted image where we can see a lot of increased signal intensity. This is more of an acute tear. The T1, these are all arthrograms, so there's high signal intensity in here because the arthrographic contrast is going into the tear. Here's a T1 fat suppressed, and here's the T2. So one of the things that we see here, we can clearly see an abnormality on the T2, but in this particular case, since this is not a displaced tear with fluid collecting into it, we could just call this tendinosis, but clearly on the arthrographic contrast studies, we can see that this is a full thickness tear. So one of the problems with T2 is that we may lose a little specificity. So you just need to understand what the advantages are of the different pulse sequences in order to come up with your impression in the report. Here's a non-fat suppressed T2. Here's a fat suppressed image. We can see increased signal intensity within the tendon, but here it really looks like we can see a partial tear of the superior surface better on the fat suppressed images, and I think the partial tears are a little bit better seen with fat suppression.
Can you go back, John?
Yes. Here?
All right. If that's a complete tear, why isn't there a little more separation of it there than what you have? I would think that there would be.
Yeah, I think this one is small enough where there's not a big enough gap to really get retraction yet. I think this might progress in that case, but we've put contrast into the joint space, and that contrast is exuded all the way through the tear and to the subacromial subdeltoid bursa. So I think this is a complete tear, but there's not going to be a big gap in it.
Where did they inject it? Do you happen to know where they injected the dye in this case?
Generally, the dye is injected, most of the time here, it's injected in an anterior approach into the glenohumeral joint space. You can occasionally get a little bit of leakage into the subacromial subdeltoid bursa, but I've never seen, just from the injection, enough to pool like this.
I get it. Okay, this is, I would be very reluctant to operate on this case.
Yeah, if it were me, I would be reluctant to have you operate on me. But among surgeons, and you probably know this better than I do, John, there's a lot of disagreement as to what really constitutes a surgical tear. Some people are very aggressive, and they say that tears that are greater than 50% of the thickness of the tendon may be surgical candidates. There's one paper that I'm familiar with in the literature that says that. Other people require larger tears, but I think the clinical presentation of the patient is at least as important, maybe more so than the actual tear shape on the MR examination. Depending upon the symptoms of the patient, I think you may be more or less aggressive at surgery. Is that correct, John?
Yeah. You see degenerative changes as you go towards the supraspinatus muscle, and so I suspect that this is probably correct. But I think this is a case that I probably would exercise and redo the MR before I would think about surgery.
Yep. Good.
Anyway, thanks, John.
Thank you. Okay. So here the tear sequence. Yeah, we've already just determined that. I think we've already talked about the difference in contrast between with and without contrast. So here's another example. On the T1 weighted image, we can clearly see that there's a lot of abnormality. There's retraction of the musculotendinous junction. the musculotendinous junction should be right around the 12 o'clock position. We're seeing that it's immediately displaced, so we know that there's displacement. We can see a full thickness tear here with ends of the tendon there, but we can also see ends of the inferior tendon in this location on the PD FatSat, and on the T2 weighted image we can really see the same thing. So this is a complex tear. There's a full thickness component out here, but there's also a partial thickness of the inferior surface where there's even more retraction. So it's a complex tear of the supraspinatus tendon in this particular case, which we can see on the MR examination. Now, the MR can also tell us about the quality of the tissues. And again, we're primarily talking about the different kinds of contrast that we see on technique. We'll talk about more pathology when we actually get to the rotator cuff section. But here on a contrast examination, we can see that there's a complete tear on the T1 FatSat with fluid extending into the subacromial subdeltoid bursa. The PD FatSat, now here, there is uptake in an abnormal tendon, so it looks like this is an area of complete tear with fluid in it. But when we go to the PD FatSat, what we actually see is this area right through here that's really bright on the T1 actually is intermediate signal intensity when we have a longer TE and a longer TR, and this is actually degenerated tendon, and the tear is actually this area right in this area, out more peripherally. And then on the T2 weighted image, we can actually see better here. So this area that's very bright on the T1 FatSat image, which is not bright on the T2 weighted image, is all degenerated distal end of the supraspinatus tendon. The tear itself is actually limited to this section. So again, you can see how if you just use a T1 FatSat image, you might grossly overestimate the size of the tear and underestimate the tendon itself. But this is abnormal tendon, even though it's dark on the T2 weighted image. So this is a case where you'd measure this as the size of the tear, and then there would be a significant degenerative disease in the distal end of the tendon. And if you have a surgeon who's really interested in it, you can measure the length of the tendon here that shows degenerative change. The reason that may be important is that often when you have this much degenerative change within the tendon, if you put sutures in it, they won't hold. So you might have to resect some of this. So in the end, after you go in and remove non-viable tissue, the tear actually may end up being significantly larger than the defect we see at this time. So we can just estimate that. I don't think MR is really good at determining how much you might have to remove here. It's better with the meniscus and the knee. But at least you can let the surgeon know that there is about 1.5 centimeters of the distal end of the tendon has significant degenerative changes. John, do you want to comment on that?
It all depends on how much fraying there is, and I'm not sure you can determine by what we're looking at.
Yeah.
I would like to know the muscle a little better, and this is a little small. The field of view is a little small, don't you think?
Well, I cut this down just to show the tendon. The actual images show more of the muscle.
I understand this, but that's why when you're asking for a surgical opinion, and I would like to see more muscle, and then decide. Yeah. But this is an operative case if the muscle is okay.
Yeah, my guess is the muscle is going to be okay. We don't see it here.
I'm sorry, when you see this much separation, you have to be prepared for quite a bit of work. So.
Okay, good. Okay. Now, one thing to remember when we do short TE images in the shoulder, that there's an area here where the field is longitudinal, like in our high field scanners, that the direction of the fibers of the tendon are going to be at the magic angle, and on short TE images you'll get increased signal intensity in this area. We'll talk about that when we get to the physics section. And depending upon what the TE is on the PD FatSat, if it's a short TE, you'll also get magic angle artifact right in this area in the tendon also. That's another reason why I like the T2 weighted images. With a long TE, you don't get magic angle artifact, and it stays dark here. So it helps us differentiate tendinosis from magic angle artifact to some extent. But in general, this your eye will, if you haven't already, will immediately look at that and just discount it as being magic angle artifact. Here's the T2, which shows the normal fibers going through it without any transverse increased signal intensity, confirming that it's magic angle artifact. Okay, I'm getting tired talking again here. Jeff, what do you think of this case?
All right, so I have two coronal, let's say T1 FatSat and PD FatSat images. It looks like on the right we have a, in the PD FatSat, it looks like we have a full thickness tear of the supraspinatus.
Okay.
With some retraction. Okay,
so this is and that now I don't know.
And is it, I guess it's a pedal line. Is that what that is?
Well,
there's a communication with the
So that's certainly what it looks like on this PD FatSat image. Actually, the musculotendinous junction is right about the 12 o'clock position, so I don't really see any retraction. To call retraction, I think it's important to look at the musculotendinous junction. So these are the PD FatSat images, and we think that there's probably a tear there. If we go to the T2 weighted images, this is what it looks like.
Oh, well, on the T2 image, there's no significant increase in signal. So.
Okay. And then we see a lot of irregularity of the acromion here. This patient went to surgery. There was no rotator cuff tear here. The rotator cuff looked normal. And he ended up having the diagnosis of impingement syndrome with subacromial bursitis as the cause here. So this is probably tendinosis of the tendon, enough where it absorbed contrast. In this particular case, the T1 was done first. By the time they got the T2, there was probably more adsorption of the contrast by the abnormal tendon, but the tendon was completely intact, and the synovium was intact, and it looked normal at the time of arthroscopy. So this is another reason why, and I've had a number of cases like this where the surgeons were all upset because the patients, actually most of the time they were, fortunately somebody else read the study, but still, and in retrospect, the T2 actually showed that it correlated better with the surgical findings than the fat suppressed images. So that's the reason, this is the reason why I always include the non-fat suppressed T2 whenever I do an arthrographic study. And I still find this to be a valuable sequence. But I'm much more concerned about false positives than I am about false negatives. So, and this has been a complaint that I've had from surgeons over the years that I've dealt closely with. Okay, but yes, John.
That's why I don't like arthrograms, John.
Yeah, and I agree. I'm not a big fan of arthrograms for a couple of reasons. One is I don't think that they help the diagnosis. Some people believe they increase the sensitivity, so people who really want to operate like to order a lot of arthrograms, and we can see that they can increase the false positive rate, I think, more than anything else. But also, if you don't need to, I don't like the idea of putting foreign substances into patients. And why stick a patient and do an injection if you don't have to? There are economic reasons why many places stress arthrography, because it brings in more revenue to the radiology department, and it can increase the amount of surgery performed. But I think in general, I'm not a big fan of arthrography. But a lot of people would disagree with that. Yes. We'll get to labral tears later. We're just talking about rotator cuff right now. I think it can be significantly good for labral tears, if that's the pathology you're looking for. There are issues there too when we get into the labrum, though. And but let's talk about that when we get to the labrum. Now, Now, looking at partial tears, here we can see T1 FatSat, we can see an inferior surface partial tear, roughly 50% of the thickness of the tendon, which some people believe is a key threshold. Notice that we don't see that very well on the T2 weighted image. So if you're looking for these partial tears, arthrography may be helpful. But there are some of us who really believe that these partial tears are not really surgical conditions. So I don't really want to necessarily increase the diagnosis of this. But if you're working with surgeons who really are very interested in these joint side surface partial tears, then you might want to do arthrography. Okay.
John?
Yes, John.
Can you go back? On the T2 image, the right one?
Yes.
That's kind of a question as to the tear, isn't it?
Yeah, see, this just shows probably a little tendinosis in that area. But what we see is that you can get tendinosis which absorbs contrast. But when that happens, you almost always see a black thin line here. We'll talk about this in much more detail when we get to the rotator cuff section. When you don't see that thin black line, that correlates very well with an arthroscopically detectable partial tear. And we'll talk about partial tears in much more detail when we get to that section. Right now, I'm primarily just talking about technique.
Okay.
Let's see. So here's a 15-year-old baseball pitcher with shoulder pain. This is the PD FatSat pre. Deshali, what do you think's going on here?
So from what we can see of the supraspinatus tendon, there's a little bit of intermediate signal along the articular side. So that may be a partial thickness tear.
Okay.
And then on the post, so we see that contrast is now seen in the joint space and uplifting the supraspinatus tendon.
Right.
So I suppose it's difficult to tell whether that's actually a real tear if that's just contrast.
Yeah. So this is probably a partial tear. There should have a nice black line along the inferior surface, which is interrupted at this location. So this shows how we can actually see that this probably is a little partial tear there. It's less than 50% thickness. So the significance of this would be very questionable. It's certainly not a surgical lesion. Whether it's associated with symptoms or not is something that's very debated right now. So it shows that there is some pathology here, but I think it's reasonable to call this a tendinosis because it really shouldn't lead to any change in treatment. So the arthrography shows it a little bit better, but I don't think that change in diagnosis would change the management of the patient. So I'm just pointing that out as differences between non-arthrogram and an arthrogram examination, because we don't often see the non-arthrogram and arthrogram in the same patient. So this just lets you see the difference of the way a lesion looks with and without arthrography. Okay. So let's see. Dan, what do you think of this case?
So we have a coronal PD FatSat image of the shoulder, which shows the germ changes of the glenohumeral joint and with kind of like marginal osteophytosis, overlying cartilage loss, and then supraspinatus tendon. At the insertion, there is increased signal. It looks like it's like a high grade, at least bursal surface tear at the insertion, and then more proximally, like or more medially, there is like articular surface tear. So in conjunction of the two, there is like a high grade partial thickness tear, and is actually retracted too. So. And on the T1.
So now this just shows a difference in contrast between the PD FatSat and the T1 FatSat. Not a lot of difference. If we go to the T2, what we see here on the T2 now, there is actually fibrous tissue in through here. And what this is it absorbs the contrast. But what we're dealing with here is a full thickness tear that's retracted. Then we have scar in situ that's developed out here. So there's retraction of the musculotendinous junction. There's an inferior surface tear that's retracted more than the body of the supraspinatus tendon. And this is torn here, but this is now scarred in with scar in situ. And what you find here, this is an arthrogram, that we do have imbibation of the contrast in the area of the abnormality, but you don't have free flow of the contrast into the subacromial subdeltoid bursa. So one thing to remember, and we'll see variations of this, is that you can have actually a false negative arthrogram, because you can have a significant tear, but if you have scar tissue in the area of the tear, it won't freely communicate with the subacromial subdeltoid bursa. So you also, in these more chronic tears, you have to be aware of that issue as well. Okay. Dan, what do you think about this case? Jonah.
Okay, so we've got a T2 and a FatSat T1 and arthrography case. So, you know, on the FatSat T1, we're just seeing sort of extensive signal throughout, and it's uplifting the supraspinatus a bit. We're seeing possible labral pathology, which we'll probably talk about in another lecture. But then on the T2, we're seeing, you know, some signal abnormality, but not very much distally. Yeah, so there's a little bit of fluid in the bursa there, which kind of blends into the overlying muscles there.
But you're not seeing that fluid.
No. Not seeing that at all, no. So,
So what's going on here?
so I imagine what we have, and we do have that sort of horizontal linear signal of the distal tendon on the T2. So I imagine what's happening is that's kind of masking a little bit of fluid that tracked around there and covering up a small tear.
So what we have here is fluid in the subacromial subdeltoid bursa here, but it's not freely communicating with the joint space. So we don't have contrast in it, and that's why you don't see it on the T1 FatSat. And then here we can see the labral tear much better on the gadolinium study. Okay. There are people in the past who have done just T1 FatSat post when they do arthrography. And when you do that, you can, if that's all you do, you can miss a lot of significant other findings around the joint space. But there are still people that'll put in the contrast and just do T1 FatSat images in all three planes. If you do that, you're going to miss a lot of pathology in the joint space. And then here's another arthrogram. This was an arthrogram T1 FatSat where we can see it looks like there's we can see the contrast, nothing's going into the subacromial subdeltoid bursa, but we can see on the T2 weighted image there's actually an interstitial tear in the distal portion of the supraspinatus tendon, which we can't see with just the T1 FatSat images. So just be aware that T1 FatSat alone is inadequate because you can see interstitial and other pathologies on the other sequences. Okay. And here's a T1 FatSat here where we can see the contrast into the joint space, maybe a little irregularity of the superior labrum. But here's the T2 weighted image, and here we can see a substantial insertional tear, or bursal side tear of the supraspinatus tendon, which in this case does not communicate with the joint space, so it's a very high-grade partial tear that you're not going to see on the T1 FatSat. Since this is right at the insertion and it's involving probably 90% of the thickness of the tendon, it's likely that this can be associated with symptoms. And again, if you just do T1 FatSat post, you're going to miss the diagnosis. So this is just to be aware. If you do the PD FatSat images, you can often pick these up in this particular case with the foot. So just be aware of the differences between the different pulse sequences, and we'll explain more of this when we get to the physics section. And here's that partial tear on the sagittal images at the anterior insertion of the supraspinatus. And here's another example, T2 weighted image where we have a suture anchor placed with some metal artifact. Here we can see the tendon is actually going all the way down to the suture anchor. The T1 FatSat post, the PD FatSat post, looks like there's contrast going all the way through the tendon, and there's a little bit of fluid in the subacromial subdeltoid bursa. Now, generally, after you've had rotator cuff repairs, actually arthrography becomes a little bit less useful because you almost always have leak. Normally, it's usually not watertight after you do a primary repair of the rotator cuff. So in a situation like this, I think the T2 weighted images are really more important. You get less metal artifact or other artifact from the suture anchors, and you can actually see the tendon fibers better on the T2 weighted image than you can on the fat suppressed images. So I believe in the postoperative shoulder, the T2 weighted images are even more important than they are in the non-operative shoulder. And in this particular case, the rotator cuff repair is still grossly intact, even though there is a little bit of leakage through it, but that's seen in more than 50. The leakage is seen in probably 70% of postoperative shoulders. So just having fluid going into the subacromial subdeltoid bursa is not valuable in the diagnosis of post-surgical re-tears. And we'll talk more about that also when we get to the rotator cuff. Now, other things you can get subacromial injections, which we can see here. It's injected in the wrong place. If you go into if it gets into the subcoracoid bursa, it can actually then communicate with the subacromial bursa and vice versa. Here's actually an injection also, not where you want it. There's no contrast in the glenohumeral joint space. We can see it's really injected into the supraspinatus tendon. So that's another reason why it's probably not a good idea to do arthrography unless there's good proven value for it. And this is just the injection into the supraspinatus tendon. Now, an ABRA view was popularized by a former fellow of mine. It was Philip Tierman, who really kind of popularized the ABRA view. And the concept here is sometimes it's hard to see anterior labral tears. So if you put the arm above the head where you put a strain on the anterior capsule, which attaches to the anterior labrum, you can pull the labrum off, allowing to see the tear better. That's the concept between the ABRA view. And there are many places where they'll routinely do ABRA view when they do arthrography of the shoulders. What I found in a study of 200 patients is that the ABRA view was only valuable in about 1 or 2% of patients. So, when is ABRA view most important to make this diagnosis? It's really in the young athlete. So typically, and the ABRA view is a very uncomfortable position for most older individuals. So generally here, we'll do the ABRA view on athletes under the age of 30, but we do not do an ABRA view on any patients over the age of 30, unless there's some specific reason. But here we don't really see an anterior labral tear here on the regular position views. When we put them in the ABRA view, we can actually see the labrum pulled off. So this is one of those few percentage of cases where we're actually able to detect an anterior labral tear on the ABRA view, but not on the regular view. But that's, in my experience, quite uncommon. But there is an example. And here we can actually see a posterior injury as well. But we'll talk about that more when we get to that. Okay, this is a patient who had an arthrogram. Jeff, what do you think of this case?
So it looks like we have, let's say, it was an axial T1 and a coronal T1. What I'm seeing is within the joint space, looks like there's a significant amount of hypotension throughout the joint space there on the axial, and also looks like on the coronal image as well.
What do you think?
Did you say air?
You
said
Sorry,
air.
was there a question?
Did you say?
Not likely. I wouldn't think that air would be conforming to the anatomy like that. I would imagine it would probably be non-dependent, and because it also seems to be located inferiorly within the coronal as well.
So it's in the.
So I think it's fluid. I think it's a fluid collection, and
it is. But John, if you inject air, it doesn't dissipate pretty quickly.
Well, air will stay in quite a while. Well, we actually, when we first did arthrography of the shoulder, we actually did air arthrograms, and it stays along plenty of time to be able to do the imaging. In this particular case,
So,
this is fluid, but remember, fluid can either be liquid or gaseous. So
what this is, but air, if you have a tear, it probably escapes pretty quick, though.
oh, if you have a tear, this is an arthrogram injection.
I know.
So, oh.
Go ahead.
Well,
I'm sorry to interrupt. I know what this is, so
Okay.
I'm just,
So this could
well,
be.
if it's an arthrogram, could it be? I mean, I'm wondering now about the. I mean, if it is arthrogram injection, I'm wondering about the concentration.
Yeah.
Is it possible that the concentration may be
Yeah.
a little bit too much?
This was too concentrated. The person who did the injection didn't dilute the contrast adequately, and this is what I think this was a 2-to-1 dilution when it should be a 200-to-1 dilution. So this is what it looks like. This hyaluronic acid can also look like this if you actually do an MR. If somebody comes from an orthopedic office and all of a sudden you see this and nobody's injected it, it could be that they had a hyaluronic acid injection at the office, and it could also be if you injected air into this could be an air arthrogram, but usually then it's darker than this, and you don't see this fine increased signal intensity within it. And this just shows these are the fat suppressed images, and there's actually some imbibation of the contrast into the bone here. But you can see it's very low in signal intensity. So what do you do in a case like this? What? Okay, so you have the patient come back. You call them and tell them to come back into the office, scan them when they get back in the office, and it's usually dilute enough at that time where you'll get an arthrogram. So you try to get them back about 3 to 6 hours after the injection, and then it's usually dilute enough where you can get an adequate arthrographic injection. Now, another technique that people have used is called indirect arthrography, where you actually inject IV so that you don't have to do an injection in the joint. You exercise the shoulder for 20 to 30 minutes, and then you scan the patient. And then what you can get, in this particular case, we can see a rotator cuff tear. We can see contrast has then exuded into the joint space. And now, the problem is that this will exude into any spaces where you have synovium. So you will also get contrast in the subacromial subdeltoid bursa because all the synovium in the body has blood going to it, so all of them will get contrast. So there are two disadvantages of this technique. One is you'll always tend to get contrast in the subacromial subdeltoid bursa whether you have a tear or not, and you actually don't have increased pressure in the joint space. I'm not a big fan of this technique. There are people in the past who have been a fan, especially if you have satellite sites where you don't have a radiologist, and the technologist or nurse can do this kind of a study where they might not be able to inject the shoulder. There are some studies that show that this was as effective as internal arthrography. That's probably because arthrography itself doesn't help a lot, and as long as you have an MR image, you're going to be able to make a diagnosis. More recent studies have really shown that in the large joints, direct arthrography is a better technique. You get better image quality than the indirect arthrography. So I've never been a fan of this. There are some people who still like this in the wrist. So that's just another technique that you may see. And then you also get enhancement actually in areas of tendinosis of the tendon as well with indirect arthrography. And you can also see it with gradient echo images, but I'm not a big fan. And the other thing that you can do, obviously, if you can't do an MR, you can do CT arthrography, which we have here, just using CT contrast. And the other thing that occasionally we've had a couple of cases in the past where patients have come in and they're allergic to iodine, and they can't have an MR scan, but you could do a CT arthrogram with full strength gadolinium contrast, and you actually see that the gadolinium is almost as dense on the CT scan. So this is actually, wait, is this it? Here's actually an arthrogram. We couldn't do an MR because of the metal artifact from the prosthesis, and this patient was allergic to iodine, so this is actually a CT arthrogram using gadolinium, and you can actually see that there's a tear with extrusion of contrast into the subacromial subdeltoid bursa. So that's a trick you may someday need to use, but hopefully not. So that's basically technique section. Any questions? Yes?
Good question. If the patient is pregnant and you give him can you do gadolinium with the shoulder arthrogram, and does that kind of cause any systemic absorption for placenta and all that stuff?
It is absorbed into the peripheral circulation. It's fairly low concentration. Most people believe that there is no increased risk to the fetus to do that. But most people also wouldn't want to do it unless there's an overwhelming demand where you have to make a decision before the baby is born. And that's because there's a 5 to 10% incidence of congenital birth defects. And you don't want to be blamed for doing something when, even though there no association between congenital birth defects and gadolinium, or MR for that matter, but there are a lot of attorneys that don't know that. So generally in pregnant women, we don't like to do anything unless there is an overwhelming medical reason why you have to make a diagnosis before the baby is born. But if you have to, I think gadolinium is quite safe. Any other questions? Okay. Well, thanks everybody, and we'll go forward tomorrow, and I think talk about impingement tomorrow.